Good evening, dear colleagues and friends. It's my pleasure and also my honor to welcome you to this ESGE webinar entitled Optimizing Your Diagnostic Upper Endoscopy Examination, Tips and Tricks. My name is Bas Weusten. I'm a gastroenterologist and professor of GI endoscopy at the University Medical Center in Utrecht, and I will moderate this session. And I'm happy to have a wonderful lineup, and I would like to introduce my colleagues and friends. First, Raf Bisschops, who will deliver the lecture on how to master the basics of upper GI endoscopy. He's from the University Medical Center in Leuven, and he's well known to everyone, probably. And the second presenter will be Rehan Haidry. Hi, Rehan. Welcome to you as well. And Rehan will discuss how to avoid common mistakes in upper endoscopy. And Rehan Haidry is probably also well known to all of you from the UCLH in London. To give a brief introduction, why we have chosen this subject of tonight's webinar. Well, a simple diagnostic upper endoscopy is probably one of the most common procedures we all do. And in training, when we train ourselves and when we train our fellows, after we have mastered the basics, then we usually seek for more challenges in more complex procedures, upper GI bleeds or dilating strictures, or we try to master stent placing. And in most webinars and also in most live endoscopy sessions, these high-end procedures are typically shown. But the aim of the current webinar is to go back to and refine the basics, how to perform a perfect upper endoscopy. When I do a list of upper endoscopic procedures, I'm almost as much satisfied when I deliver a near perfect upper diagnostic gastroscopy as when I do a complex esophageal ESD. And that has something to do with a mindset. If you are focused on constantly improving your skills, also in the routine standard procedures, you will have more pleasure and satisfaction. And then a regular diagnostic upper endoscopy is not boring anymore, not something in between more exciting procedures, but they are a challenge in its own. And that is what the three of us hope to achieve with this webinar. Well, having said that, I have two housekeeping slides before we start off with the first presentation. During the lecture, there will be a couple of polls, and you are invited to answer the questions in the polls, and hopefully that can be a starting point of a discussion. And there is also the possibility to ask questions through the Q&A functionality. Please do so, and I will try to pass on the questions to the presenters, and otherwise we can answer it through the Q&A by typing some answers in the facility there. The next thing is that you can earn a CME credit tonight. You will receive your CME credit certificate after you've completed the survey that will be sent to you by email after the webinar. But in order to earn the CME credit, you have to attend the full webinar. So please be aware of that. So without further ado, I would like to introduce Raf Bisschops once again and invite him to take the floor. Raf, please.
Thanks. Good evening, and thank you, Bas, for your kind introduction and for suggesting this topic, because we really need to go back to basics sometimes. Things that are taken for granted and trivial can be challenging, and obviously we want to perform well in everyday practice, and I think that's what this is about. So I would like to address these different points and really go step by step through these different points in your upper GI endoscopy. So let's start with the preparation and the pre-procedural plan that you actually need to have every time you do an upper GI endoscopy. So I would like to start by asking the question, if you use systematically simethicon prior or during your upper GI endoscopy. So you can vote here, and then we can see how many of the 500 attendees are using this systematically. So let's see, you can vote. Let's have a look at the voting. So about 72% does not use it systematically, and 30% uses it systematically. So let's see why we can consider that. We come back to that in a minute. So first, start with simple things like fasting instructions prior to the upper GI endoscopy. We should not overdo this, because if we ask patients to fast too long, this can be a burden on the patient. And there's little evidence, but some evidence available that we should fast for solids for 6 hours and at least 2 hours for liquids. And if we summarize this evidence, first of all, if you do that, you see in these studies there was no risk for aspiration, but the visibility increased when you fast 6 hours for solids, but there's no difference in visibility if you fast 8 hours for liquids. So you can allow patients to drink water up to 2 hours prior to the procedure, unless they obviously have a severe gastroparesis. Always, for any procedure, but also for a basic gastroscopy, you have to wonder whether there's a good indication. Is this endoscopy really necessary? What is the comorbidity of the patient and the risk benefit? If a patient comes into your office to evaluate a cancer and can barely come out of his wheelchair without desaturation, there's not going to be any consequence in confirming the diagnosis, and you shouldn't even do the procedure. Also, if a patient with standard reflux symptoms and without alarm symptoms comes back for another endoscopy for reflux, you should wonder whether this is really necessary. Also ask yourself whether you need to take biopsies. If somebody with dyspepsia comes in, you want to rule out HP and celiac disease, for instance, and have it prepared. Is there an indication for chromendoscopy? For instance, a patient with a history of ENT cancer, where you want to screen for squamous cell cancer and you want to use Lugo. It's better to have it ready than to prepare it during the endoscopy. Also, taking into consideration, if you have to take biopsies, ask whether the patient is on anticoagulants. Do you need sedation? Well, that's a question that is very often asked, and the answer is actually simple. You need to be able to see the mucosa during your endoscopy. And if that requires sedation for that particular patient, you need to provide it. So ask about previous experiences, also the patient preference. They may be very scared and anxious to undergo the procedure, and that could be a good indication for sedation. Take the comorbidities into consideration. You don't want to just sedate a patient with severe pulmonary disease without taking precautions. And then maybe you have to ask yourself, do I need to do the sedation with an anesthetist around? And if you choose for sedation, prepare the monitoring, which includes blood pressure, pulse, oxygen saturation, and capnography. Also check your endoscope every time. We need to explain this to the fellows, but I do this in everyday practice. For every endoscopy, is the insufflation working, is the suctioning working, and is the lens cleansing working? And now coming back to the simethicone. Remember, this study was done in patients that were not sedated. Otherwise, you may actually have a small risk of aspiration, but if they're not sedated, you can actually give them a mixture of 100 milliliters of water plus 100 milligrams of simethicone. And this, in this study from Portugal, increased the visibility to an excellent mucosal visibility significantly throughout the esophagus, stomach, and duodenum. So you can see here, the orange is the water plus simethicone, which improves the visibility significantly, especially in the stomach and the esophagus, in comparison to water alone. The addition of acetylcysteine did not change a lot here. There is this nice meta-analysis looking at studies using visibility scores or the number of patients with good visibility. And you can see that each time it is in favor of using simethicone prior to the endoscopy. But obviously, you should do more than just giving simethicone. It requires also sufficient air insufflation and aspiration to expose the entire mucosa. So now let's come back to the very first step of endoscopy, upper GI endoscopy, which is the scope introduction. This may be very trivial, but just let's go through it. You need to pass certain barriers during the introduction, beginning with the teeth, where you use a bite block. You have to pass over the tongue and then find the epiglottis, go behind it, and then you have to locate the arytenoids. Remember that most of the space in this area is occupied by the respiratory structures, and the esophagus, in fact, is collapsed between it and the spine. So potential hindering could be caused also by vertebral structures like cervical arthrosis. Also watch out for Zenker's diverticulum and ask your patients beforehand if there's any symptoms of high dysphagia. Now let's have a look here. It's a video by Bas Weusten. And so you always choose either right or left. So you pass the barriers, you locate the arytenoids, and then you dive into this hole and you lift up the wheel. So this is the big wheel down and then the big wheel up again, jumping over that barrier here. So that's very nicely done. And you can see also that a cap in difficult cases could facilitate your entry. This is another thing, another movie indicating the importance of aspiration. So don't flush while you enter, because this can cause a lot of coughing. But on the other hand, if you run into a little bit of remnant saliva, like you will see here, right here, just aspirate this and don't push it into the airway, because this can cause coughing as well. So Bas is hesitating to go left or right here, go behind the epiglottis, and then go again into this esophagus. So when you do this, we refer to this, I like this, I saw this the first time introduced by Jack Bergman, to jump as a dolphin over this barrier. So you actually choose the right or the left or the right side of the arytenoid. So this is the way into the esophagus. And then you have to jump over this first barrier, which lies between the vertebrae, so the spine, and the airway. So and this is first, you have to actually pull your big wheel down to overcome the first barrier, and then to rectify and go back deeper, you have to push the big wheel up again. So it's actually like a dolphin jumping over a hoop. So this is what you have to do each time. So putting it together, don't do this blind, look at the screen, aspirate whatever is in the throat, identify your landmarks, the tongue, here the epiglottis, then you move on to the arytenoids, you can see them here, and then you choose right or left, and then you jump into that esophagus like a dolphin over a hoop. So it's basics, but sometimes if you realize what you're doing, it becomes very easy.
Raf, may I jump in here? Because this is, I think, a very important issue. And what I would like to ask to you here is, do you look into the bite block yourself? Some endoscopists tend to take the endoscope, look through the bite block until the endoscope disappears behind the tongue and then look to the screen, or do you start looking to the screen from the moment you put your endoscope at the level of the bite block? What do you do?
Usually I look at the screen immediately, but sometimes you can have a very thick tongue where it makes it difficult, so you get stuck and then you have to see to get really to the back of the throat. But once I pass the tongue, I always look at the screen. Yeah, but it's a very, very good and practical question. So, but it's not systematically that I look into the mouth. So usually you can identify it, but if you have a thumb which is in the place, a tongue in the place, then I would do that.
Yes, I would like to encourage the endoscopist to look at the screen as much as possible, and not to, because there's always a blind moment when you switch from looking into the mouth of the patient onto the screen. You don't know what happened then, and then you can be lost. So I would like to enforce that you try to stick to viewing the screen.
Yeah, I totally
just
agree.
One comment on that, if I may, on Raf's excellent presentation, is that, as Bas said, and Raf, there's also pathology in the mouth, and it's really important that as soon as the endoscope enters the bite block, it's important to look at the oropharynx as well. And I've diagnosed early squamous cell cancers of the hard palate in patients. So I think it's really important, your point is well made, that always inspect the oral cavity if you can, and that's where sedation comes in. So sorry to interrupt, but I think that's a good.
Oh, that's a good point. Actually, my first or last picture of an upper GI endoscopy is very often the vocal cords that I try to visualize. Okay, so next point is to optimize visibility and cleaning. So we mentioned the simethicone, which you can use if you're not using sedation, but usually nowadays we use also simethicone in the esophagus or the stomach. It's very cheap. You can produce it yourself in the endoscopy suite. The concentrations can vary. I think it's not very well defined. And I already start in the esophagus, like here, using 50 to 100 cc, obviously quite carefully that you don't overdo it and the patient starts to aspirate. So it's a bit less liberal than you can do in the stomach. And the good thing is, once you have it in place, especially in the stomach, you can additionally rinse with water. You dilute it further, but you can still use the characteristics of the simethicone to decrease the bubbles by diluting it and spreading it out. So this is what you see here. And once you enter in the fundus, obviously we always have to keep in mind not to cause any aspiration, and usually there is still some acids and fluid in the stomach there. So you start by aspirating the fundus like you see here. And then I move on to the antrum, where I would do some additional cleaning. You usually will have some saliva or bubbles there, like here, and we rinse that again with the simethicone syringe. You may wonder why we have to use this syringe and cannot do it with a water jet, which we did in the past, and was actually much more elegant and efficacious, I think. But unfortunately, I mean, there's been reports that the simethicone in the water jet channel can cause a biofilm, and therefore it's not advised anymore by our hospital hygienists to use it like that. So after that, we clean the stomach. I come back to the fundus, as you can see here, and we clean this further. Once that is done, then you're ready to go and move on to the duodenum to continue. And just to show you why this helps, and Rehan will add more to the mistakes. So just rinsing off everything highlights these lesions, like here in the stomach at the angulus, or here the subtle lesion here at between 3 and 12 o'clock before delineation. So this is really why we want to clean everything, just like in the colon. And we take it for granted to do a Boston bowel preparation scale, but we don't have this for the stomach, but we should do it ourselves. I mean, if everything is covered with mucus, you can't see anything. The next thing is then to, after cleaning, is to come to a systematic inspection. So we ended at the pylorus, and now we're ready to enter the duodenum. You want to reach there as far as possible, but the entire process, and Rehan will also talk about photo documentation, is quite dynamic. You can see, I see the papilla here, so I freeze the image, and only when the image is nicely frozen and you see it's sharp, then you should take a picture. So don't take pictures if you have a food pile which is connected to a video card. You can take pictures continuously, obviously, but you want to have a nice frozen image that is clear, that goes into the patient file. And then you can take pictures, and Rehan will say how many pictures you need. You need at least 10, but obviously it's not forbidden to take more. You can take 30, 40 pictures, you can take a video, whatever, but at least you should visualize the duodenum, take a picture there, the papilla if possible, and then the bulb. And usually for the bulb, you have to go back. You come back into the antrum, and then you have to move back forward, like here, to nicely visualize what made it be there in the bulb or not. Then we have a nice view on the pylorus, and you see that the systematic approach with the photo documentation just continues. So you take photos of every part, the antrum, and usually what I do then is to angulate onto the angulus to have a good visualization. Sometimes you have hidden lesions there. And now that you've moved to the retroflex, I usually already inspect the entire stomach in retroflex while I further insufflate. So now we move up towards the fundus and to the cardia. This was actually a case of Barrett's esophagus. And you will see that one of the things we do is actually to pull, in those cases, the endoscope into the hiatal hernia to have a full inspection into retroflex, into the hot zone, which is situated here at the 3 o'clock position in case of a Barrett's esophagus. This can sometimes be a little bit difficult, and you have to be careful not to get the scope stuck in the esophagus. So if the patient starts retching or coughing, you have to be ready to push the scope back in. But now you can see a nice view here on the start on the distal esophagus and the GI junction, which you should have. And again, you took a picture of that. Then it's time to inspect the full fundus, aspirate and insufflate. So it's also something I very often do simultaneously. When I apply suction, I also insufflate, not to lose all of the insufflation. Still a little bit of mucus here, but we can accept that, I think. And you can see nicely here the fundus. And then we move back forward to the forward view, take again pictures of what we see. We see some fundus cystic gland, and this one looks a little bit off. You can see there's a little bit of blood just after rinsing without suction. It has a bit of a different appearance. So you have a closer look. This draws your attention, and this will be taken out because it has a different appearance than all the other glands, than the fundus cystic glands. And then we move back again to the antrum. And another thing that I want to emphasize while you do this systematic inspection of the entire mucosa and the photo documentation of the abnormalities, what we show you here, I think it's also useful to use advanced imaging. It doesn't hurt the patient. In this case, this is normal, but it helps you, and Rehan will allude to that even further, to find subtle lesions, right? This is how you do it. And you really want to use these techniques because, like, for instance, here you can nicely see how this highlights the intestinal metaplasia in comparison to the white light image. Or even here, it's a very subtle lesion here, which is a little bit pinkish. And then if you put a little bit of Lugol on it, you can see the star-shaped squamous neoplasia. Or here we use the BLI modus, where this type 2C lesion in Barrett's esophagus is accentuated, or this type 2B lesion squamous in this esophagus. Just some examples. I mean, it's just pushing a button. So while you pull back from the esophagus, taking the pictures, do it once in white light when you inspect your Barrett's, and make sure you inspect everything.
Raf,
yeah.
And I have a couple of short questions from the audience. The first question, or maybe remark or question, is: should you take photos when you go in or when you go out after cleaning everything? The argument for making pictures when you go in is that you might traumatize the mucosa by your endoscope and then creating artificial lesions. At least that is one of the Gerard Isenberg mentions this. What's your opinion?
Yeah, it's a good point. You should obviously pay attention not to cause injury, especially in the bulb. I think you can have some scraping of the mucosa, which can cause a little bit of bleeding or mucosal damage. It's a good point. I think you can do both as long as everything is clean and you visualize everything. I usually do it on the way back, but obviously you need to remember, if you apply too hard suction somewhere, that this is an artifact, right?
Exactly. Also has something to do with how gentle you apply suction, right?
Yeah, exactly.
One other short remark is that Khalida mentions that she always take pictures from the duodenal bulb when she just enters the bulb, because otherwise you have to re-enter it again, and that might increase the discomfort of the endoscopy. It's a good remark, I think.
Yeah, it's just as valid. I'm just showing you the way how I do it. So there are many ways and many roads to Rome. So I think as long as you visualize it accurately, and freezing when you go in is a perfect solution. Yeah.
Sure.
Especially in an unsedated patient, that totally makes sense.
Exactly. Sorry for interrupting you. Go ahead.
No problem. Pleasure. So let's move on to the next step. So how to take biopsies. Well, let's put a question here. How many biopsies do you take at least for eosinophilic esophagitis? So is this 2, 4, 6, or 8? So we will briefly go over the different indications quickly, but let's see. Yeah, that's very good. So the majority says 6. 8 is also good. So it's definitely more than 6. So 6 and 8 were both a good answer. 4 and 2 are unfortunately not enough. So let's move on. So the important thing is, first, take your time to look for lesions. I think we explained that, and Rehan will go more into detail. If you find one, inspect first the rest of the organ before taking the biopsies, right? And in case of lesions and the need for random biopsies, take targeted biopsies first and then collect them in separate containers. Sometimes that means that in case of, for instance, a Barrett's esophagus or a stomach with intestinal metaplasia, you need to have kind of a map in your head where to take these lesions. I usually ask my nurse to write down where the visible lesions are. And that makes sense. You know, if you have these lesions that I show you and you start taking your random biopsies here, it will be a lot harder to find this or that again. So take first the targeted biopsies and then all the rest. So for eosinophilic esophagitis, you need to take at least 6, so 2 to 4 in the distal esophagus and 3 in the proximal esophagus, and they advise us to put this in 2 different containers. For reflux, you don't need any biopsies. For candida, also not really, unless it's going to change your practice, but you can identify it endoscopically. For viral esophagitis, 6 biopsies of the base of the ulcer and the edge. For dyspepsia, we usually want to exclude HP, so, and also intestinal metaplasia. So take 2 biopsies of the antrum and the corpus in separate containers, and 1 biopsy of the angulus that goes into the container of the antrum. Fungal cystic glands don't need to be biopsies. If you have a typical hyperplastic polyp, biopsy or resect if it's more than 10 millimeters, and an adenoma, biopsy or resect. And for celiac disease, 6 biopsies from different locations in the duodenum, at least also 2 from the bulb. So this is a nutshell what you can read in the recent guideline from Wolfsbau. And one particular issue I want to highlight is taking the biopsies of neoplasia. So if you have early neoplasia, flat, small lesions like here, that may be amenable for endoscopic resection, you should only take 1 or 2 targeted biopsies to prove there's neoplasia. However, if you have more bulky lesions that need to be resected surgically, then you should at least take 6 biopsies in case you have bulky lesions like this. And for suspected linitis plastica, you should take at least 10 bite-on-bite biopsies. So take a biopsy, and in the place of the biopsy, you take another one to rule this out. So one particular thing is the Seattle protocol, where you take more biopsies every 2 centimeters, 4 quadrant biopsies, and we report them according to the clock system, where the 3 o'clock is the less the curvature of the stomach. So for instance, we use something like 3803, that would be 38 centimeters from the incisors at 3 o'clock. And if we take random biopsies at that level, we would say it's 38,100. So how to take biopsies in the esophagus? Well, if you want to target this island, for instance, you really need to pull the biopsy forceps close against the endoscope and then approach the mucosa or a lesion. And you can't do this with pushing the forceps out of it, because then it becomes very difficult, because any small movement will cause a lot of movement of the biopsy forceps. So really do it like this, like you see here in this nice movie. And also apply suction to approximate the mucosa, and don't push the forceps against the wall, because by applying suction, you can actually get more into the forceps and get better biopsies. And sometimes you can rotate, like you can see here in this video from Bas, when it's a little bit difficult to target this island. Sometimes you want to get it at a different position. So you keep your biopsy forceps close to the endoscope. You approach the target, let's say this is a lesion or this island, and then you apply suction, you close, and then you can easily take a nice juicy biopsy if you do and use this technique. Especially in the esophagus, this is a bit more challenging and important. Take them one by one. You're going to lose half of the biopsies because you're so tangential to the wall, and you will lose the first most of the time anyway. So for a Barrett's, if you see a lesion, you report it, take a biopsy 5 o'clock at 32, it goes in a container 3205. There's another lesion here, goes into container 3405, and then you have to start this tedious Seattle protocol and the C8 and 9 Barrett's, where you take 4 quadrant biopsies every 2 centimeters, and they go into different containers. So that means a lot of containers for the pathologist to analyze. But I think this is the way we should do this to get a real full mapping of this Barrett. So finally, the adequate reporting is also important. Just want to ask you, do you systematically use a Paris classification to describe lesions that may be neoplastic? Yes or no? So we need to use standard terminology. We come to that. And it's good to see that 70% uses this. That's really a way forward, I think. So there are several things that need to go into report: the indication, what kind of sedation you used, the procedure time, and Rehan will tell you why in a moment. So he will explain all this. And then we need to use the standard terminology. So for Barrett's esophagus is the PRA classification. So the C stands for the circumferential extent and the M for the total mucosal extent. So that means that C is always smaller or equal to M, and not the other way around. Right? And the reason why we want to have the standard report is it actually improves the quality and the detection. So this is a recent study looking at mentioning of these landmarks and the use of PRA classification, and that itself already led to a high detection in people using this. This was 36 versus 13%. So just the way that you take these pictures, you do report it and have a good look at all of this, makes that you find more lesions. For reflux, we use the LA classification. You can look this up. For the caustic injury, use the Zager classification because it determines the outcome of the patient. For varices, you can use the Baveno classification or Northern Italian Endoclub classification because it's been validated. Peptic ulcer bleeding, we use the Forest classification because it again predicts the outcome of the patient and what you need to do with the patient. For FAP, we use the Spiegelbein classification for duodenal polyposis. It's been under discussion, but at least it gives an idea about the severity of the problem. And here is the Paris classification. So what do you want to use? You have pedunculated lesions on a stalk, sessile lesions that are bigger than your biopsy forceps, flat lesions, 2A slightly elevated, 2B very flat, and 2C slightly depressed. And then you have ulcerated lesions when your biopsy forceps fits into the hole, it's ulcerated. And the reason why we want to use this is because it tells us the risk of potential submucosal invasion in many of these lesions. So this brings me to my conclusions, Bas. The first thing is know your patient and indication before you start your upper GI endoscopy, and then follow a specific and systematic approach from intubation, cleaning, dedicated inspection, and photo documentation. Know how to take your biopsies and how many to take of them, and then make sure you have a high quality report, and that would complete a very good high quality upper GI endoscopy. Thank you.
Thank you for this wonderful presentation, and I think you highlighted a couple of very important issues, and there are a few questions which I think we have a couple of minutes to address those questions. You talked about mucolytic agents or simethicone. It's not the same, but let's say simethicone. Do you give it before the endoscopy? You only mentioned rinsing or administrating it during the endoscopy, but what do you normally do? Do you give it before the endoscopy, 30 minutes just before the endoscopy?
Yeah, if you do it in an unsedated patient, you can give it 30 to 60 minutes prior to the endoscopy. That's how they do it in Portugal, I've learned. Many of our patients are undergoing sedation, and that's why we use it during the endoscopy immediately, right?
Maybe it's important to say that it doesn't necessarily need to be 100 ml. If you give a small cup of simethicone, it probably does the job as well. And that prevents, of course, aspiration if you are sedated. And another interesting question was, do you have any tricks if a sedated patient is not able to hold the air and you lose the air constantly when you're inflating the stomach, or any tricks?
Yeah, tune up the insufflation, I would say. I think this is mainly a problem in unsedated patients, because there you will have the reflex to belch, actually, that is triggered by distension of the fundus. So maybe if it's in unsedated patients, sedation can definitely help there. And sometimes you have to accept it. And what you could do is then really put on a cap and try to search in between those folds better. But I think sedation is usually the issue that solves the problem. Yeah, if patients belch less, then it can be solved.
There are many more questions, and I'm afraid we have not time to answer all questions.
I will answer them.
Yes, I already answered a couple of questions while you were talking. One final question before we move on to Rehan, and that's an interesting one. Are you afraid of spreading malignant cells and seeding them if you take biopsies of the lesion first and then do random biopsies of the esophagus?
I think it's a theoretical, interesting question.
There are some data from the colon, right?
Yeah. I don't think there's study addressing that. Personally, I don't have that experience, I must say, because we used to take a lot of biopsies, at least for Barrett's, let's say, prior to ablation therapy, where we did a systematic mapping after resection. I think what is important is really that to ask your nurse to clean the biopsy forceps really in between every biopsy. I didn't mention that here, but that's one part that's more nurse technically related. And we did get recently an instruction that they really should use running water to do that, not just wiggle in a little bit in a cup of water, but really clean it very thoroughly. And I would certainly advise to do that if you've taken biopsies from a cancer. Yes.
Great. Thanks once again, Raf.
You're welcome.
Well, Rehan, the floor is yours. Avoiding common mistakes.
So thank you very much, Bas, and also thank you to the ESGE for allowing me to be part of this fantastic webinar. And I've already learned so much from Raf's talk. And as Bas said, I've been trying to answer some of the questions in the chat function as we've been going along. So what are the common mistakes in upper endoscopy? The thing is that we need to give ourselves every chance to allow our patients to demonstrate any pathology, and that comes down to good quality imaging, washing and sedating patients, but we also need to know what we're looking at. We need to understand what the classifications are, what our endoscope is taking us, and take lots and lots of pictures. And we need to sample. If you're not sure, take biopsies. If you're not certain, take another biopsy. And then we need to be careful of things that are going to catch us out. Esophageal strictures, for example, we mustn't miss the cancer. The stomach is a big, big place, and gastric ulcers can be pre-malignant. So we need to know what we're looking at, and we need to follow these up. And we moved a long way. So this is a picture of Basil Hershowitz doing a fiber optic endoscope on his fellow in his garage. We're very lucky now because we have wonderful endoscopes. So let me start by a small question for the fantastic audience watching tonight. So this is an old endoscopic image of a gentleman who presented to the emergency room with complete dysphagia, 56-year-old gentleman. I'd like to ask you, ladies and gentlemen, what do you think the diagnosis is here? So do you think it's esophageal cancer? Do you think this is candidiasis? Or do you think this is the foreign body? Just going to give you a few moments to reflect on the picture that you saw, and I'd be interested to see what your answers are. So that's interesting. Okay, well, in treat esophageal cancer is by far the most popular answer. Now, unfortunately, you're wrong, and the 36% of people who said it was a foreign body are correct. So you need to describe what you see. This is a, sorry, just go back a slide if I may. This is a gentleman with esophageal cancer. So some of you are right. However, he had declined the use of conventional chemoradiotherapy or surgery and was eating live mice. And it was the 86th mouse that he had eaten that had become entrapped at the esophagogastric junction. And you'll be pleased to know that the mouse was rescued with a forceps biopsy and lived a happy life thereafter. So describe what you see, very important. What are the challenges for all of us? The drive for early diagnosis is really big, especially after the pandemic. National cancer strategies and waiting lists mean that we need to scope patients early. There's a massive increase in demand for upper endoscopy through primary health, so through primary care. And as a result, we need greater number of endoscopists. We need to enhance our training and reduce the variation in experience. And why is quality important? It's because we need to give our patients the best possible outcome, the best possible examination. And we know that evidence exists that the better we are, we will protect against cancer, we'll have fewer complications, and the patients will have a better outcome. And cost effectiveness, especially in this current climate, is very important. And do we need to improve? Of course we do. We talk about common mistakes, but we all miss lesions. This meta-analysis suggested that actually, if you look at upper GI cancers, nearly 1 in every 400 cancers, we were overlooking an early neoplasia. What about Barrett's esophagus? Lots of data shows that up to 25% of patients with esophageal cancer and the preceding history of Barrett's esophagus will have had a normal endoscopy in 12 months. Now, it could be because we have a very rapidly progressing lesion in that time, but the likelihood is we've probably overlooked it. So here, ladies and gentlemen, just to go back a step, is another short video for you. And I'd like you to have a look at this video. And I'd like you to think, what do you think the diagnosis is here? This is a gentleman who was referred with adenophagia and had a screening endoscopy this is a white light image. This is now using the Pentax technology with iScan enhancement. And you can see that the entire tubular esophagus just doesn't look right. There's a lot of food residue. And then what we're going to do is we're going to use some of this dye called Lugol's iodine. And this gives you a very characteristic picture. So ladies and gentlemen, if I could ask you, what do you think the diagnosis here is in this gentleman? Is it candidiasis? Is the diagnosis Barrett's esophagus? Is it indeed reflux esophagitis, or do you think this is early squamous cell carcinoma or squamous neoplasia? So please use the voting to give us your answers. So what you saw in that previous demonstration, as most of you, in fact, the majority of you have concluded, is an area of a squamous neoplasia enhanced by Lugol's chromoscopy. So very well done. And what are the common mistakes? Endoscopic diagnosis of early squamous neoplasia in the Western scenario is very difficult because unlike Barrett's esophagus, there is no pit pattern and the changes are in superficial vascular structure. So you need to be careful when you see things in the mid-esophagus. You don't get candidiasis in isolated patches. You don't get food sticking to the esophagus. So think about what you're saying. So what is the solution, ladies and gentlemen? We need to adhere to quality standards. There are BSG and also ESGE guidelines that stipulate that we need to do is, like Professor Bishop said, electronic reporting systems that are homogeneous, and we are avoiding duplication of data, but we're also reducing the need for free text. What's the minimum amount of gastroscopies we should be doing? This is difficult, and a common mistake that is made, and I see it, are enthusiasts who are doing the occasional gastroscopy every now and then. That is a big mistake. We need people doing a minimum of at least 100 gastroscopies. The more you do, the more you see, the more you learn. So really, really important. This is an aspirational standard. Let's talk a little bit about something we were talking about with Professor Weusten, fasting instructions prior to endoscopy. You know, how do we fast the patients? We know that if you fast a patient for 1 hour as opposed to 6 hours, you're going to see a lot more in the patient who's been fasting for 6 hours because you're going to get less confounding and you're going to get better visibility. We also know that pre-medication with simethicone and Parvalex, which is a mucolytic, will improve visibility during upper endoscopy. And this has been shown in a randomized control trial published by my colleague in Portsmouth, randomized patients undergoing standard gastroscopy to either a pre-medication with simethicone and acetylcysteine. And you can see that the patients who had just water alone compared to those who had simethicone and acetylcysteine, not only was the preparation excellent, but they were also able to pick up more lesions. So please wash again. And if you're not sure, wash again, so you can give yourself every chance of exhibiting some dysplasia. Accurate photo documentation and landmarks is really important. Take pride in your endoscopy pictures. Make sure that you're getting the best possible pictures of the individual landmarks. I was astounded when I first visited China as a junior doctor, as a junior consultant to learn. They were taking in excess of 48 pictures of all the important landmarks. The ESG recommends that we take a minimum of at least 12 patients at all your relevant stations: the proximal esophagus, the mid-esophagus, the distal esophagus, the esophagogastric junction, the cardia, which is a hot zone for buried of indolent neoplasia, all of the relevant stations in the stomach, the pylorus, the duodenal bump, the ampulla, and the duodenal, the second and third part of the duodenum. I'll go into this in a bit more detail. So take enough pictures. Professor Bisschops has published on this before, and this is really, really important for when patients come back for follow-up and are scoped by endoscopists who may not be the same, but also for retrospective learning and audit. Now, we spend a lot of time talking about how long we should take looking at the colon. God, so many lectures on inspection time in the colonoscopy. It's so boring. Why don't we do it in the upper GI tract? Really, really important. A common mistake: slow down, take your time. And we need to be able to show that that by a careful, well-timed inspection in sedated patients, we will pick up high-risk lesions. This was published some time ago by colleagues in Hong Kong, patients who had a very slow versus a fast examination. would have a higher pickup. I don't think you need a study to tell you this. So take your time, put the timer on. If you're more than 7 minutes, then you've given your patient every chance to show you something. Again, this is a nice study, again, published in Gastroenterology. Longer observation time increases proportion of neoplasia in upper endoscopy from Korea. And have dedicated lists. So this is an elegant study by my colleague in the United Kingdom. How many times do we have mixed lists, and then you have a patient with Barrett's esophagus and you have to rush through? And what this study showed is if you have dedicated lists for your patients with Barrett's surveillance, they diagnose more dysplasia. So you're not rushing, you're training the eye. It's better for the operator, better for the patient, better for the nurses. We also know that if you take longer inspecting a Barrett segment, you will pick up more dysplasia. This is a common mistake. So we know from this rather elegant study from Pratik Sharma and his group in Kansas that for every minute that you spend looking at 1 centimeter of Barrett's esophagus, you increase your dysplasia yield. So take your time, especially in patients with known pathology. Make sure that you factor in the time in your endoscopy list and your clinic time to be able to exhibit to be able to administer the correct duration. I'm not going to spend too much time on this because Professor Bisschops has talked about terminology, but we really need to homogenize the way that we describe things. Barrett's esophagus, the CNM classification, and we've looked at all of these different classifications. This is the one that we need to know and love and be able to instinctively quote in any report, because this helps to tell us about the depth of invasion of lesions. But you need to know what you're looking for. Use your best endoscope and look for subtle things. You can use the classification systems, but things that should ring alarm bells are asymmetry of the tubular esophagus, asymmetry of the mucosa, non-flat areas, nodules, ulcers. They're bad news until proven otherwise. Friability, if you find a piece of tissue starts to bleed very quickly, and then look at your mucosal and vascular patterns. And dysplasia detection is hard in the esophagus. Gosh, even the experts get this wrong. This is a nice study from Holland, which showed that patients who were referred to expert centers with dysplasia, that even in expert hands, 40% of patients who were referred without a lesion, we found a lesion. So this can be very, very difficult. And the endoscope can tell us lots of wonderful things. It can tell us about regular architecture of the mucosa and the microvasculature. So equip yourself with what normal looks like, and then abnormal will become very, very easy. We see disorders in the micromucosa, in the microvasculature, and this will tell us whether it's inflamed or indeed it's early cancer. So a common mistake is trying to jump in to look at lots of abnormal tissue, but we need to do lots and lots of normal examinations, and then we will be able to see what abnormal looks like. And then help yourself, use dyes and sprays. We know that acetic acid chromoscopy meets PV standards. It allows us to pick up dysplasia that otherwise we would miss. Ladies and gentlemen, this is a patient that was, apologies. My slides have just overrun very slightly. So this is a video of a patient that was referred with low-grade dysplasia. And you can see from this endoscopy that there is a segment of Barrett's esophagus, and we're using first white light endoscopy, and then we are using some enhancement features with the virtual chromoscopy. And at first glance, when you look at this, you can see a raised lesion in the 2 o'clock position, and that is what catches your eye. Ladies and gentlemen, actually now when you look at the lesion and the esophagus in a little bit more detail, and if we give ourselves a little bit help and we spray a bit of boring vinegar or acetic acid, which we can get from the canteen, all of a sudden we get a lot more information. So we have been focused on this area in the 2 o'clock position, but you can see the lack of acetowhitening on the contralateral wall in the 7 o'clock position. This was an early cancer, and we would have missed it without using acetic acid. So ladies and gentlemen, Now I'm going to move on to the stomach. The stomach is a big place, big place, and we don't spend enough time looking at it. The reason being is we need a station-based systematic technique. We need to look at the different areas of the stomach. We need to inflate the stomach, wash the stomach. We need to systematically look at the antrum, look at the incisura, look at both sides of the incisura, work our way across the lesser curve into the cardia, the fundus, and then work our way back across the posterior wall and into the greater curve, and then back to the anterior wall and the posterior antrum. And it's really important that, again, as I said, we know what normal looks like. In the antrum, the tissue is very, very different from, example, the corpus. So we have these ridged, almost sort of metaplastic mucosae, whereas in the corpus, we have slightly different pit patterns. So gastric atrophy is something that we underdiagnose. The bird's eye view, you will see this last slightly pale, a loss of the folds of the stomach. So, you know, a mucosal view, you'll see this, you will see these irregular collecting venules, which alarm bells will start to ring. It can be a little bit friable. And so when you're describing this, you need to not only be able to differentiate normal from atrophic mucosa, but you need to be able to determine the extent of the atrophy. So this, ladies and gentlemen, is a patient you can see referred for upper endoscopy, and all of a sudden you can begin to appreciate the this is just with white light endoscopy, these rather pale areas that begin to exhibit themselves in the 6 o'clock position of your video here. These are areas of gastric atrophy. And then as soon as we now begin to go into the antrum and the posterior antrum in the retroflex view, you can see there are no gastric folds here. So this is panatrophic gastritis. You can see there's a flat stomach. There's lots of areas of paleness, and then you can see these abnormal collecting venules. And then as soon as we then begin to look at the different stations, you will also begin to see intestinal metaplasia, and you see with narrowband imaging these concentric little rings. So lots of different examples here, ladies and gentlemen, of an atrophic stomach. You can see the lack on the left, the loss of folds. On the right, you can see this is sparing that part of the stomach. And again, here you can see that atrophic border. So look, but understand what normal is, and then abnormal will shout out at you. In intestinal metaplasia, with white light imaging, you will see these small, pale, white-gray elevated plaques. You know, spend some time to look at these, look at this light blue crest sign that you get with narrowband imaging, really handsome pictures, and it gives you great satisfaction to be able to take a picture of this and to describe it again. Here's another example and another example. And that will allow you to then pick up dysplasia. Dysplasia, anything that looks slightly amorphous, anything that looks irregular, will allow you to diagnose dysplasia, and then know your biopsy strategies, know the Sydney protocol. Ladies and gentlemen, mortality from upper GI cancers is still significant, and there's a lot of variation in practice, and we need to improve our hit rate. We all need to improve. We're in a wonderful profession that we're constantly learning and having a streamlined approach to how we inspect, how we report. Our procedural process will improve our early detection and patient outcomes. Take your time, wash, invest in knowledge, and practice over and over again. Thank you so much for your time and attention this evening.
Thank you very much, Rehan. Wonderful presentation, as usual, highly instructive. Also, the gastric imaging, I must say that last. A proper imaging of the stomach is quite difficult, as you mentioned, because it's a large area. There are many difficult, also highly difficult to interpret lesions. That's where I personally struggle often with subtle or small polyps. I think, well, those are hyperplastic or those are inflammatory. Can you comment on that? What makes you decide to take a biopsy for what small lesions, and what do you take out and take no biopsies of? Well, hope you understand what I mean.
Yeah, of course I did, Bas, and that's a really important question. I think I have two comments. I think that the stomach is a large area, and I think that we should all endeavor to have a station-based approach for inspection as opposed to just looking randomly. And I think that station-based approach needs to start. And I think that if you start in the distal stomach and work your way through those stations, so pylorus, look at the incisura, look on both sides of the incisura, then retroflex, work your way down the lesser curve, look at the proximal stomach in retroflexion, look at the proximal cardioesophagus, and then come down the other side of the stomach, looking at the greater curve, and then end up back in the antrum. So you do almost a 360. What that does, it systematically gets your brain configured to looking at these stations. And your brain can only interpret so much information, looking up, down, left, right. So I think that's the first thing. And the second thing is, you can't biopsy enough, right? And we know that polyps in the stomach go back to basics. The endoscope will give you the information. Look at your Paris classification, then look at your mucosal classification. Fundic polyps have this sort of glistening appearance upon them, but we know the gastric guidelines, anything that is more than 1 centimeter, be afraid. We mustn't miss early cancer in the stomach. And we know that, it is almost as prevalent in the Western world as Barrett's neoplasia. So biopsy, and the same with, hyperplastic polyps that are more than 1 or 2 centimeters can harbor, although very, very rarely, dysplasia. We need to biopsy them and we need to remove them if appropriate.
Well, I cannot agree enough with the systematic approach you stressed upon, because that's in all aspects of endoscopy, that's very important to have a strategy to investigate the entire surface. One other short question: what is your concentration of acetic acid?
So we use 2%.
2%.
Of acetic acid. Some people use 4%. We have it pre-made in pharmacy, and it works very, very well and has no side effects whatsoever.
Good. And I have an additional question to you or to Raf, maybe to both of you. What are typically the procedures you wish to do under sedation? And are there any particular procedures you always schedule on sedation?
So I think this is, Raf, if you don't mind, I'll start. I think this is where planning your list is really important. So if you have a patient with Barrett's, if you have patients with known Barrett's esophagus, patients with known varices, patients who are coming back for gastric ulcer follow-up, patients with known gastric intestinal metaplasia, these are the patients where you're going to spend more time. So I always say comfortable patient, comfortable endoscopist. So make sure you dedicate more time. These are the patients where you're going to have to put in a bit of extra sedation. But your patients who are coming straight from primary care, who are going to be your patients with dysphagia or dyspepsia or heartburn, etc., where it's just going to be a diagnostic scope, you can schedule less time and you can just drop down your sedation needs if required. Raf, I don't know how you do it.
Yeah, I personally feel that unsedated endoscopy is more to accommodate the hospital and the physicians and the nurses' time and efforts rather than the patient's comfort. So how do I approach this? If somebody comes for the first time and you see they're like anxious and shaking and very nervous, it's good to give them sedation. You don't need to hesitate. If somebody feels confident, then you can try if it's a short procedure like Rehan says, and it would still need to allow you to do a 7-minute procedure, right? That's what the numbers show you. And so you cannot say it's one big in and out and patient's retching all the time. So if that happens, you have to come back. So we give it a try if the patient wants to and is not really reluctant to undergo the procedure without sedation. That's the first thing. And then if they tolerate it well, I've done 30-minute Barrett's procedures and 50-centimeter Barrett's patients that tolerate that perfectly, right? So then there's no need for sedation. So I think the real answer is here that it is on a per patient basis. And just like you say, if you have a poor bowel prep in your colon and you say, I could not see anything, that should also be in your report. If somebody's retching all the time and belching and doesn't tolerate the procedure, you should say this procedure is inconclusive. and either the patient should come back, or if he is accompanied that day, then you should still give the sedation.
Really good point. Yeah.
Yeah. And usually the younger patients don't tolerate upper endoscopy as good as older patients. The ones who I endoscope without sedation are usually the older patients, and some can really tolerate it very well. But most young patients, I do it with sedation, because otherwise it will be a struggle. And they are, well, they're spoiled for the rest of their life, because they are very anxious to have a follow-up endoscopy once the first endoscopy has turned out to be a disaster. So I'm quite liberal in giving sedation. And especially what you mentioned, Rehan, in patients in whom you want to do a surveillance for either gastric precancerous lesions or Barrett's, or some squamous diseases which have a higher risk of neoplasia, such as Rehan, for instance. I always do it on the sedation to make it as ideal as possible. I think that's also, well, that's what you have to offer your patients, the best endoscopy you can offer them. Right, have you anything to add, Raf or Rehan? Otherwise, I think we should end the session, because it's 8 o'clock, at least Central European time, 7 o'clock in the UK. But nevertheless, anything to add, Raf?
No, not really. I would like to thank everybody for the interaction. So very interesting questions, and thanks for organizing this session, Bas.
Yes, and there are still a couple of questions in the Q&A. I'm not sure whether we can answer them all, but we will try to do our best when the session is over for a quarter of an hour or something. And if we don't answer your questions, sorry, don't be offended, but it's too many questions. One final word for you, Rehan, or?
Just a couple of comments. First of all, extend my thank you, but also to I've learned a lot just from the discussion, from Raf's talk. But we as endoscopists, we have a wonderful, wonderful vocation. We're always learning, and that comes from doing more and more and more. There isn't a session or a week that doesn't go by where, with a simple diagnostic endoscopy or colonoscopy, you don't think of something that you haven't thought of. And I think that that is that's the message. The more you do, the more you learn, and take your time and enjoy it. We're very privileged to do what we do.
Exactly, I couldn't agree more. Well, let those be the final words of this session. Thank you very much, Rehan. And of course, Raf, thank you also very much. And well, now we have come to the end of the session, but not before I have shown you this slide. The ESGE Days 2022 will be organized again, April 28th to the 13th of April. And that is a hybrid event, so you can also connect virtually. Well, there is one full day of live endoscopy. There are many sessions, both scientific and also educative sessions, with a wonderful faculty, and also hands-on training, so don't miss it. And if you register now, there is some nice discount because of the early bird registration. Well, this is almost the last slide before we round up. There are many benefits of the ESGE membership, and I would really encourage you, if you're not already a member, please become a member. It's not only because of the financial benefits if you subscribe for meetings, but it's also because of many other aspects. For instance, my ESGE tutor, that is that is on the website of the ESGE, and there you can find highly illustrative modules, teaching modules, for instance, on performing polypectomy, doing Barrett's stuff, upper GI bleeding, and more, and much more. So that is very interesting. And also the ESGE Quality Check app is something which comes with the ESGE membership, and that can be very valuable in your daily practice. And there are many more benefits, so please check out the website of the ESGE to find out what is in there for you. Well, the next ESGE webinar will be in 2 weeks' time from now, on February the 16th, same time, other subject, of course. And well, then the last thing I have to do is to thank not only Raf Bisschops and Rehan Haidry, but also the ESGE Governing Board and the excellent webinar team, and in particular David Inker and Gabi Varga. Well, I wish you all a very pleasant evening, and I hope to see you soon at one of the upcoming webinars or in April at the ESGE Days. And a good night. Bye-bye.